I will record. Hi, good evening, everyone. Welcome back to another webinar. This time we have Dr. Tengku Hidayat, my colleague from Beacon, and he's a consultant hematologist. He has actually spoken for us before last year. And this time we have got good news because Beacon is trying to start our own program. Come tell us more about it before you start your lecture. Okay. Need to answer.
I got a message. Got a call from Dr. Ibrahim.
Okay.
Sorry about that. Apologize because just on time he called. I beg your pardon. Yeah.
Okay, so I heard there's good news that Beacon is starting our program headed by you.
Yeah. Not just basically it's a team. So Beacon and as well as the second hematologist Francis is there.
Yeah.
So we figured it's time that we have done a soft launch last week that we already launched a autologous bone marrow transplant, which if for those who are not aware of that, I will also present a bit in our presentation. Yeah.
Okay.
And on top of that, we hope to start cell therapy, mainly CAR T therapy, which is in line with blood cancer treatment. So the approved indication for CAR T is mainly for blood cancers. Yeah. So it's something that I will mention as well in our presentation. So it's expanding slowly but surely, small unit, but hopefully with our expansion in Beacon 2 later on, that we have more beds and we'll get more busy.
Yes.
Yeah.
So maybe you'd like to share your slides?
Yep, I'll start now, yeah? Let me minimize a few things. Okay, feel free to stop me if you want to ask and make this more conversational and much more bearable for most people. But for the public, we will entertain the questions after the talk. Yeah. Okay, I'll start now. Yeah. Hi everyone, I'm Dr. Tengku Hidayat. I'm a consultant clinical hematologist at Beacon Hospital. I would like to thank Beacon and Dr. Betty's platform for having me tonight, Beating Hearts. Also, it's nice to know that it's already sharing platforms with Doc Quitty, also which has big outreach, and congratulations on that. And hopefully we can create awareness about various medical problems. And today we'll talk about a topic. It's quite a large topic, so I don't know what I put myself into because it's a leukemia on its own. Is each type of leukemia is also a big overview, but I will try to give an overview. Of course, it won't be too detailed because it's hard to cover everything, but I can answer detailed questions if you have any. Yep. Okay, the contents of my talk today, I will be starting about just to start for people to have a general understanding is type of leukemias. Then I will be talking about therapeutic targets, what is being targeted by each type of the treatment, and how we use risk stratification of a disease to guide the treatment. And the biggest chunk of this presentation would be treatment approaches. Okay, to understand how we approach leukemia, we need to understand the hematopoietic system. Then we look, there's two major lineage of the hematopoietic system. First is the myeloid lineage, and the second is the lymphoid lineage. And the myeloid lineage differentiates into many types, mainly the myeloblast, which differentiates into the various white cells like neutrophil, and basophil and eosinophil and monocyte, and as well as the other myeloid lineage, which includes the erythrocytes and the megakaryocytes. And the lymphoid lineage is which differentiates into the lymphocytes and T lymphocyte, B lymphocytes, and plasma cell. So this is important because each treatment, each lineage has its own approach of treatment, although some treatment overlaps and can be used for both, either or. So leukemia, we can divide it many ways. You can divide it to acute leukemia and chronic leukemia. Yes, in acute leukemia, we divide it mainly into AML. The long name is acute myeloid leukemia, but I cannot be repeating it every time. So AML, and a very specific subset called APML, because it's considered almost separate from AML, from the pathogenesis as well as the treatment approach. And secondly is the ALL, which is from the lymphoid lineage. So this is a normal bone marrow with normal differentiation of all types of degrees of maturation in the bone marrow of the white cell and the red cell and the platelet. So in AML, you have, in any cancers, you have proliferation of certain type of one type of cell. Here is you can see the blast here. If you cannot see, I hope you can see it. There's a nucleolus here. Reduced and nucleocytoplasmic ratio, enlarged nucleus. So it is only one type. So it infiltrates the bone marrow. It suppresses the other normal cells, leading to anemia, infection, and bleeding. Yep. So AML is generally, unfortunately, a disease of the elderly. Prognosis survival in AML is not so encouraging because it's still difficult to treat. And you can see even a young patient, the prognosis survival is about 53%. And as you grow older, the likelihood of survival is much lower. And it will certainly determine how we approach the treatment of AML. Yeah. So ALL is different.
Sorry, can you go back to the previous slide again? So it's a disease that can actually happen in any age group?
Any age, but more common in the elderly. Yes, more common in elderly. So unfortunately, the elderly is more, you can see, majority of you see 60 to 69, the survival is not so encouraging. So we are still, despite the advances, we are still trying to catch up with this. The treatment is trying to catch up and how we can overcome. However, we also have to understand the reality of the average age of most people, 70 plus, 77, 75. So we also need to be realistic. If you kena AML 80 years, if you expect to live another 20 years, sometimes we have to be realistic as well.
Yes,
yeah,
true.
but what we can do, although we don't treat, we can provide quality. There's a lot of approaches, treatment, which includes palliation. Yeah. Okay, so I can move on. ALL is also, this is similar, you can see is much large nucleus, much reduced NC ratio. It's more bluish in the cytoplasm, if you can see it. But also it's the same problem, same type of cells. It proliferates and it suppresses the other cells. And ALL is a disease of extremes. At the age of less 10 years, it's a disease of a very young group. So that's why many pediatric patients have ALL, and also the elderly. And it's good in children, 1 to 10 years. Most children do not relapse. Those who get treatment, who get diagnosed at less than age of 10 years, but very poor in elderly. There is also a specific group they call the adult young adolescent, a difficult age to treat because there's an overlap in how we treat them as adults or pediatric. It's called adult young adolescent. It's called AYA group. Yeah, so multiple factors why it's very difficult. Apart from the disease, is also the psychological aspect of how we treat a young teenager. Yeah, and who's not really an adult but thinks they are an adult. So it's very difficult psychologically as well. Chronic leukemia, move on to chronic leukemia. There's CLL and CML. Yeah, it's you can present with a lymphadenopathy, but also sometimes it's also in CLL. It presents incidentally, usually without any symptoms. You notice increased white cell, but you can see the nucleus is much more mature. It doesn't have blast, but this is are all lymphocytes with and you can see these burst cells. So it's not blastic in nature, but it's just increased in number. But it can also cause problems that you see in any type of leukemias, which is suppressing the normal cells. Yeah. So in bone marrow, you can see it's mainly the lymphocytes. Yeah, the CLL lymphocytes. It's a disease of elderly. Fortunately, it may not require treatment, where patient will be continually observed and watchful waiting, and without requiring any treatment even. Yep. So this one of, if you have a leukemia, this is you don't want to have leukemia, but this is certainly the most mild of all the leukemias. CML, meanwhile, yep. Oh, okay.
Okay, this
so
is the
CML,
best leukemia to get.
Yeah, we don't want to have leukemias, but yeah, but it's certainly, especially it doesn't require treatment most of the time. So we can, and again, when you diagnose it at elderly age, where you can live your normal life up to the age expectancy, then it's fine. Of CML is different. So this is disease mainly when you see, I mentioned myeloid lineage, you'll see all the proliferation at every stage of maturation, all the neutrophil, the band neutrophil, the mast cells, the eosinophils, so everything gets proliferate. So this is where you will have the enlarged spleen. Mainly, you don't really get much lymphadenopathy. So since spleen is the most of myeloid organ, so you get a proliferation, yeah, and you see all types of cells at different stage of maturation within the myeloid lineage. Survival is also affected by the advance in treatment, a breakthrough treatment called imatinib, which I will explain later. It's a disease of many of the younger group of age. So you can see 15 and 44, the survival up to 64 is more than 70%. This is very encouraging. And of course, when elderly, the survival, overall survival is much reduced, between 36 to 50, between 35 to 50%. Yep. So CML is also a type, you don't want to have any leukemia, but it is one of the type of leukemia which has good survival rates. So it's not the end of the world when you hear leukemia. So to everyone who's listening, there are many, not all leukemias is an absolute death sentence. Yeah, others I shall not talk about because this is very rare. Burkitt's leukemia, mantle cell leukemia, both which have lymphoma site of the presentation, hairy cell leukemia, and other plasma cell leukemia, which we encounter, but not too common. Okay, so now we move on to the therapeutic targets. Yeah, we usually target as any cancer cell, we target it at the cell cycle. And there are also immunophenotypic cell surface markers. Yeah. Then also there's also cytogenetic and molecular markers, where this is the opportunity where there are a lot of advances in treatment which targets. We are trying to move away from the age of chemotherapy to more targeted and immunotherapy. So cell cycle division. So any cells, especially cancer cells, will divide and proliferate. And suppress the normal cells, and they divide, they proliferate, and they don't die off. There's lack of apoptosis. So this is where we attack the cancer using the chemotherapy. Then this is also done not during the cell division growth, but the whole cell cycle, which is in both the GO, G1, S, and G2 phase, which is cell growth, DNA replication, and prior to mitosis. Yeah. And cell surface markers is quite not so recent, but considered more recent, about 20 years plus. The breakthrough was in B cells, in lymphoma, and leukemia. You have markers, CD20, which can be a target for treatment. So we use antibodies mainly, and this is also encouraging advancement of the treatment of cancer. The other one is, you can hear is cytogenetic molecular markers, which target the molecular abnormality or the oncogenes. Yeah. So here you can see this is Philadelphia chromosome, where there is a translocation of 1922. So you get a short chromosome here, Yep. So this is the pillar level chromosome, this 22q, and the oncogene, which will produce a substrate, which causes the problem. I will explain later on. And a much more detailed one is the molecular markers, which is we have, which we can detect from initially PCR, but now next generation sequencing NGS, you can detect the whole event on the panel that you order. You can detect what's the suspected molecular markers. Yeah, so this, apart from prognostication, is also available as a target. So you have a lot of targets which you can potential targets to be attacked by our treatment approach.
Sorry, go back to that NGS. This one is only for is a test to be done for any cancer?
Yes, each cancer has its own. So we few labs support where we but we need to know which panel you order. So you cannot be like, it's not like a whole
it's not like a
whole body. Yes, you need to know what to order.
It's not like a comprehensive thing like, okay, A to Z.
No. There is an update. They want to do a comprehensive whole body, but I forgot the name. But it's still under development and is still not approved yet. But this is also considered a good, because by identifying this also, you also know that you manage to treat the cancer not just at a cellular level, but also at a molecular level. If you do not detect it at the molecular level, you know you achieve a very deep remission. So this is our very exciting and very hopeful approach that we can treat this disease. Of course, it's still considered early days. We don't manage. So the report will come out like this. And if you have some abnormal markers, you will have suggestions. Some labs will suggest what kind of treatment or drugs can be used as based on the what data and literature we have on this each. So it's very good and very helpful. So it's also but the other thing is the cost lah. For instance, a very expanded panel in AML, it will cost 8,000 ringgit alone, this test. So, but it is worth it if you have the capacity to pay for it. But of course, we don't have to have this to treat leukemias. We also go by the limitation of the center and the patient's financial capabilities. Yep. Okay, so now we move to risk stratification guided treatment. So based on the cytogenetic and the molecular abnormality, whether we do it from PCR or NGS, we can divide, because this will be apart from prognostication, it will also determine how intensive we treat the disease. So AML has its own, AML has its clinical and genetic markers. So does ELL, yeah. So if it has all this data to determine the type of treatment, because for if you based on this you can prognosticate. It also helps you in counseling, prognosticating the patient, as well as knowing how aggressive or how less intensive we want to approach the treatment. CLL as well, it's also now we have a very organized risk stratified approach for everything based on clinical data, as you can see here, based on the blood levels, whether there's existence of lymphocytosis or organomegaly, yeah, and based on anemia and thrombocytopenia, you can get a good idea on how to approach. So here is the cytogenetic markers. So this will help how we treat. Guide how we'll treat. CML, not really. It's basically prognostication. When we use when we use risk stratification, it's mainly prognostication. So we treat. Of course, it's helpful in counseling patient in prognostication, but the treatment is generally similar nowadays. Okay, treatment approaches. We have chemotherapy, we have immunotherapy, we have targeted therapies, bone marrow transplant, or what you call it, hematopoietic stem cell transplant, and cell therapy. This is all not, you don't take it as each, a lot of patients would come to you, I want immunotherapy, I don't want chemotherapy. And a lot of people people have actually abused these terms, putting immunotherapy or targeted therapy in their products and thinking patient thinking is the better option, chemotherapy. They take this bogus treatment. They do not get a proper treatment, and by the time they come to us, it's usually too late. So in any cancers, including in blood cancers like leukemia, you never think that you can choose what type, but of course, there are some that you can use monotherapy, use one of them. The doctors would like to reduce toxicity to patient, but most treatment approaches still requires a combined modality, which I'll explain later. Okay, chemotherapy, as I said, that we have many group classes: alkylating agents, anti-metabolites, anti-tumor, antibiotics, and vinca alkaloids and natural agents. So when we mentioned antibiotics, I had a patient. She's diagnosed with AML. Her platelet is 2 white cell. Initially she came at 100, and now at one point it came at 500. I had to use urgent chemotherapy to treat her, but she still refuses to take proper chemotherapy. She read a pseudo-medicine book which tell antibiotics like doxycycline and together with metformin, which to starve the cancer with from sugar, will kill the cancer cells. But she's still alive, and managed to see me frequently for transfusion, and we support her. I do not deny patients for treatment. Some people may approach. We do not support the treatment, but I think. We as long as we manage to consult patient properly, they know the risk involved. We just support and try to give them a good quality of life, regardless of what the options. So my approach to her was I still support her even though she doesn't go for this treatment.
Wait, hold on. She on antibiotic.
Yeah, so she was actually not demanding. She was trying to push me to give her doxycycline and metformin to treat her acute leukemia, AML. Basically, because based on some person may have read the book that antibiotics can be used to treat cancer. So because it is true that we use antibiotics, but what we're using are at mega doses and super high concentrations, not the one that we take orally on normal IV to treat our infections. So she uses metformin also to starve, because a lot of people, it is true, cancer cells use sugar, use energy, but patient is non-diabetic taking metformin. I don't know. I hope she doesn't get lactic acidosis. So, this is the basic chemotherapy classes which we have.
Going back to this anti-tumor antibiotics, they are not exactly antibiotics, are they?
Yeah, actually, they are based on the antibiotics, but given at high doses. So the basis is not antibiotics. It is like the basic. Yeah, but it's not common But so that's why this knowledge has been abused to So
that's how her thinking. That's how she started thinking about it.
True. So because people can be convincing by talking about a doctor or some health talk about, since doctors are for instance, the Western conventional hematologists, oncologists are using antibiotics, why don't we use antibiotics of our choice, which is safer, less toxicity, because toxicity is a main concern for any chemotherapy. So this is the worrying thing But whatever we need to advise and document properly, so we know that we have given the patient the best options, and they know that we disagree. So it's not easy for us to withdraw treatment, just say I don't transfuse her at all or do not treat her with antibiotics at all. That would be heartless, I feel. That's my opinion. So we just support them. So this is the thing. So principal chemotherapy, so at different level of the cell cycle, this is where it works. That's why we don't give just one type of chemotherapy. We give combination therapy to hit the cancer at different stages of the cell cycle, including the division. Yeah, but some are independent of cell cycle, so they work even at the resting period of the cell. And also at the dividing period of the cell. Okay, so you have this all chemotherapy protocols. There's all nomenclatures, banyak, a lot of types. You can see it's all protocols, combination, so it's never one type. You can see it's combined with targeted therapy. You can see here it's combined with immunotherapy. So it's all combination, yeah? So it's never one type. So we move on to immunotherapy. This is a very smart way. So based on what's the cell markers on the cell, because on your cell you have markers basically as protein antigen markers. This can be used as a target. So monoclonal antibody is an antibody which goes and attaches itself to these markers and does its job of killing the cancers. There's two types: monoclonal antibodies. Another type is bispecific monoclonal antibodies. I'll focus on one in leukemia treatment. So the most famous one is rituximab. It's used both in ALL and CLL. And obinutuzumab is this anti-CD20. The history antibody, basically your cell surface markers has this antigen called CD20. So the history of this monoclonal antibody is a chimeric antibody made of human and mouse cells. So it's designed to attack and attach itself to the markers, so it kills. So both it has complement-dependent cytotoxicity, antibody-dependent cellular cytotoxicity. It can cause direct cell death. It makes the macrophage attach and attack it there. So it is used to kill all the cancer based on the using your immune system and as well as direct killing.
So when you use this monoclonal antibody, do you need to give chemotherapy?
Yep. Some like CLL, sometimes you can use monotherapy. Because sometimes you consider patient's age and comorbidities as well, because the chemotherapy carries risk of infection, especially those in an anthracycline group. In your specialty, can cause those with heart failure or very poor heart. We try to avoid those anthracycline containing drugs. So you can still use this. But most of the time it's used together with combination with chemotherapy and sometimes with targeted therapy for the synergistic effect of the cell killing, the cancer cell killing. So this one is still so it has multiple modalities how it kills. So it attach, so it directly kills or uses the other cells like your macrophages, the host natural immune system. So it sort of encourage them to kill off the cancer, induce apoptosis. Okay, so another one is in AML also, but not it's still used. This one is special a bit. It binds to it brings the drug in and actually releases the drug into the cell and kills all the cells. So it works differently. Some encourages the cell to encourages your immune system to kill, but some are bound to drugs which carries the drugs inside the cell. So many approaches and how it kills the cell. Then finally, for the monoclonal antibodies, is blinatumomab. It's bispecific, so it's very specific. So it links it targets the CD19, a marker of the cancer B cell, with a normal your own T cell. So it binds it together, so enhances the T cells to directly kill the B cell. So it's like it links this these two. Yeah, but it comes with a risk as well, because you have the cytokine release syndrome. Because you have a lot of the cytokines release, you may get cytokine release syndrome, and you may need to use antibodies and sometimes steroids to control it. So this is also quite is a high risk, because you need to manage the complications, especially the cytokine release syndrome. Yeah. Okay, now we move on to targeted therapies. Okay, the most famous is the breakthrough is CML, tyrosine kinase inhibitors. It changes how we approach cancer treatment, not just for blood cancers but also for solid tumors. So because it targets a substrate, a cancer substrate. So when you have the Philadelphia chromosome, the translocation occurs. You have the BCR, ABL, oncogene 22q minus, and the production substrate. The substrate encourages proliferation, thus causing the chronic, the CML. So what it does, this imatinib, this targeted therapy, it goes and blocks the ATP, so you do not produce the CML, so it stops. So it's a breakthrough. It's an oral therapy. Most targeted therapies, which ends with is an oral type therapy. So patient does not need to go through chemotherapy. They just need to take oral therapy. Imatinib now has its generic type, so the cost has also come down. So it's very accessible to the public, and even the original one still has a very encouraging patient assistance program where the drug company helps to bear some of the brunt. So this is very encouraging. This is a breakthrough medicine in all cancer treatment.
Does it work on the bone marrow or on the?
It works when it divides. So the BCR, it works on bone marrow, it works in the peripheral. So you when you take the BCR-ABL level, you just need to take it at the peripheral blood and monitor it from there. So that's the sort of the cancer marker. So we have a cancer marker based on PCR, which is the BCR-ABL, which is the cancer protein. So we have a target. We have the best is deep molecular response, or even, but most of the time we are happy with the major molecular response. So we just want to detect less than 0.1% of the cancer substrate. Yep.
And again, this target therapy has to be done with the chemotherapy?
No, it is done as a monotherapy. So you use it as a
monotherapy.
Yeah, so imatinib is a monotherapy. It is a breakthrough medicine. This is a differentiate treatment. So a lot of cancer treatments, the targeted therapies are derived from this approach. So it was in, I think, 1999 or 2000. So it was certainly a breakthrough. So previously people were treating CML with chemo, interferons, and transplant. So those carry risks, especially transplant. So this sort of changed. That's why you can see the younger age group, the survival is very good for this for this disease, almost 90%. So it's very good, yeah. Especially with the newer types, you can achieve deeper response, yeah. So that's the whole target, because with deeper response, there's also chance to have a drug holiday. Yeah, so meaning you can stop the medication for a while, so you don't have to continue taking it. Yeah. Okay, so we move on. Similar, CLL has this. I focus on ibrutinib because there's a main one, and in how we treat. So similar. So it blocks, it induces apoptosis, induce adhesion. Okay, may cause apparent lymphocytosis, but our lymph node will naturally go back to the lymphoid organ, so it doesn't allow the lymphocytes to go back. So it same idea. Basically, all this targeted therapy is to block the substrates to prevent proliferation and induce apoptosis, but the target is at the molecular level, substrate level. And AML not, but CLL, CML has good outcome from this, and CLL we can treat it also with oral therapy only, but most of the time it needs combination of either one type of ibrutinib, one type of targeted therapy combined with other, or with chemotherapy. Yeah, AML not so encouraging, but we do have options. Yeah, so we have based on the molecular abnormalities. Yeah, so that when from NGS we may. We have certain types which can control the disease. So this is a summary. So a combination, sometimes CAR-T, immunotherapy I mentioned earlier, These are all at the molecular levels. It blocks the cell induced apoptosis and stop cell proliferation.
Hold on.
APML.
Sorry, can I just ask you, when you do use the target therapy, right, and you say that it's monotherapy, and is it for lifelong?
Monotherapy, yes. Unfortunately, some, most it's lifelong. So when they say lifelong, they say 2 years or until disease progression, because lifelong. That's the challenge of this. The limitation of targeted therapies. Majority are lifelong medicine and that's why new advances are made. For instance, like CML with the different types to induce a deeper response and maintain response, because one thing is to induce a response, but the other thing is to maintain the response. So this will allow people to allow the doctor and the patient to have a chance at stopping the medicine. So in CML, there's a stop trial which allows the patient to them to have a very deep molecular response for certain years and stop it. This is important because especially this is a disease of a young, and they need to have a normal life, for instance, get children. So while on this, they are not being able to be pregnant. So this is one of the reasons. Another thing is toxic effects. So if they have to get pregnant, you cannot be on targeted therapy. You need to stop it. So there are many approaches how to deal with this situation. For instance, like patient getting pregnant, but one of the approach is the chance at stopping treatment. Yeah. So but when we stop treatment, there's a risk of it relapsing and gaining resistance to the existing drug. So it's one of the things that we are still under trial and a study. So nobody has a clear answer on that yet. But there is a chance to stop trial. But most needs lifelong therapy until disease progression. But lifelong usually is 2 years. The program that we have 2 years. But
I see. Your lifelong is 2 years.
Yeah, because data is not enough, because we don't have any.
Okay.
Yeah, so and some of them remain difficult to treat where the disease progress even before 2 years, But
I see.
It is a good option because it's an oral thing. Yeah.
But
So
the word remission is very very.
Remission is not cure. Remission is not cure.
Remission is not cure.
Remission is not cure. It's disease control. I don't have a graph here. Imagine it's an XY graph. So you have the real zero. You never reach the real zero because there is a limitation on how we detect cancer, whether it's from molecular tests or PCR tests. So what we want to reach is as close to zero as possible with this combination therapy, all this. So you may need, that's the reason you need many cycles of chemotherapy. Even after you reach remission, you need extra chemotherapy to get as close to real zero as possible. So yeah, that's why we talk about 5-year remission, 10-year remission. So this is a cure. Cure that I'm not sure the confident to say cure, because cancer we use the word remission, so it's control. That's
for the public and even a cardiologist like me. The word remission means probably cure, right? Yeah. Because I have done even and I have done like a year of PITS oncology. So did it dealt with
but we still call it remission, but PITS oncology, ALL still remains, you don't see them relapsing so often. That's why the outcome is better. That's why they're able to tolerate a stronger intensive chemo. Kids are quite resilient and they can survive intensive chemotherapy. So this is the approach. So APML also is a breakthrough medicine where initially APML, the story was when you get APML, the likelihood of mortality was 90% before this Atra medicine. So what happened is in APML, you have a cell arrest at this APML. You see all these granules here. These are all procoagulant. So when it gets released, you get both clotting and bleeding disorders. Patient die of bleeding from APML. But with this PML-RARA, it blocks it and it encourages differentiation of this. So it doesn't put the cell at rest, so it differentiates normally. And this is also an oral treatment. Yeah. So, but this one you can almost, this is also success because from 90% of mortality rate, if you manage to manage the control and treat the complications within the first 2-3 weeks, the likelihood of success is 90%. So this oral, simple oral medicine is changed the whole outcome of the disease. So it's very amazing. But of course, you can use it, it's used together with a chemotherapy. But some centers, especially in elderly people, you cannot commit. So it's just two types of medicine. It's both, here is in IV formulation, but you have an oral formulation. So you control an acute leukemia with oral medicine. So that's really very good and very nice to hear. So this is APML. So it's a success story. Yeah.
Oh, but
so now we move.
Your oral medication sounds very toxic. Arsenic.
Yeah. You of course you have the you have to monitor because you have the QT prolongation. Okay, with you need to do an ECG. You have to monitor that. You have to monitor lah. So, but it is amazing that we managed to treat leukemia without chemotherapy using targeted therapy. Yeah. So we move on to bone marrow transplant. Yeah. So we finished already on the targeted therapy. So bone marrow transplant is still a major approach in treatment. So in leukemia, so we divide it into autologous versus allogenic. Autologous means you use your own bone marrow, and allogenic you use a donor's bone marrow. So you need a sibling. It's either siblings, parents, or unrelated match donor lah. Yeah, parents. There's many subtypes called haploidentical, match unrelated. So we shall not focus too much on that, but just understand the principles of it. So autologous, what we do is we collect the patient's stem cell. The other name for autologous bone marrow transplant is high-dose chemotherapy with stem cell rescue. Basically, what you do is you keep the stem cells. Yeah. You must achieve a good remission first of the disease. Then you keep your stem cells, you store it. Then when the one that kills that the cancer, the remaining cancer, when I mentioned as close to zero as possible, is the conditioning treatment. Very strong high-dose chemo. It's just like you're rebooting your system. So you once you kill off you give the conditioning chemo to kill, you reinfuse your stem cells to replenish your normal red cell, white cell to encourage the recovery of the bone marrow. Yeah, so that is the principle.
When do you harvest this stem cell? When you are already diagnosed with leukemia?
That's the thing. It's autologous, not so. It's not really only in relapse APML you use it, but in all other you use allogenic. So because I will speak about allogenic. The reason that we use allogenic, yeah. Is what we do is you use a donor's, basically you put another person's immune system in you. So the principle also, you try to achieve a good remission first, then you harvest, you identify a donor, you harvest the donor's one, you store it. Before your transplant, you give a conditioning and treatment. It can be chemotherapy alone, can be together with whole body irradiation. One is to kill off the remaining cancer. And secondly is to create marrow space and immunological space to allow the donor's marrow immune system to be infused into you. And the additional effect of this allogenic is using the your donor's immune system, your basically hematopoietic system, to achieve a graft versus leukemia effect. So graft versus leukemia is double-edged sword. You attack the leukemia, but you also need to manage the complications. So you may get graft versus host disease, which can be very difficult to treat you need to use immunosuppressants for it. So when you use immunosuppressants, you put the patient at risk of infection. So the challenge, the additional challenge of allogenic versus auto is this mainly this graft versus leukemia effect, graft versus host disease. But you do achieve a good graft versus leukemia effect. Basically, the donor's immune system is attacking, because your immune system, which is usually your hematopoietic system, your T cells and NK cells, has failed to kill off your cancer. So you're using a donor's immune system to help kill off the cancer, to achieve a remission and prevent relapse. So role of bone marrow transplant is actually consolidation. You do not transplant in a very in a raging disease, in an aggressive disease. So you use it as a consolidation to reach as close to as minimal. We use the term minimal residual disease as possible. If possible, we want it to be undetected. Yeah. So it also reduces the risk of relapse. Yeah. So that is
wait, hold on.
basically
We go back to this bone marrow transplant. Let's say I don't have leukemia, but I keep my stems. What cell?
Or your stem cell, hematopoietic stem cell, your bone marrow stem cell.
Yeah.
There's no indication for that because if you keep for your own stem cell, you is only you do not expect that you have lymphoma, because it's lymphoma and leukemia is not like those breast cancer or colorectal cancer. If you have like family history, you know you'll get it. Yeah. So it's not that. So there's no benefit. Even cord blood also, there was very trendy cord blood.
I was coming to cord blood.
It is useful in those with pediatric. It's useful for those at pediatric age, because the dose required to stem cell, you need to give it according to the patient's body weight. So you cannot use the cord stem cell, hematopoietic stem cell, to treat an adult.
I see.
So
but there are.
Yeah, but maybe for pediatric, yes, it is. It has its role, and of course, it has its advantages and disadvantages. Because you can harvest the stem cell either from peripherally or from your bone marrow directly, of cord blood. So there are different. But despite that, cord blood is still a source. But for adult, is not a viable source of stem cell.
Okay, and I'll ask one more question. Okay, bone marrow transplant, because we are now also broadcasting to the public. Can you tell us whether is there any risk to the donor or not? Because
so the donor, you won't get cancer for sure. The only risk is during the procedure, because we will give some stem cell boosters, white cell boosters, we call CSF booster, which will release your stem cell to your peripheral blood. So with this medicine can cause bone pain and the other thing what we worried about, splenic rupture, but it happens very rarely lah. So it's one very rare complication. So that's one of the risk. If the patient doesn't want that, then sometimes we have a direct bone marrow aspirate where we poke the bone marrow 20 times, and patient is under GA lah. So that's one thing. So basically a procedure-related risk procedure. Risk. Another one is when you do if you do it peripheral harvest, because most of the time you need to put a central line, whether from IJC or femoral catheter. And when you put in, of course, you get the complications of bleeding. Any procedure, we put a needle in someone's body, you can get bleeding risk, infection risk, but those are very low. And when because it goes, you put yourself on the machine. So during that time, you may get low blood pressure, but the risk to the donor is very minimal. So do not worry. Is actually you're saving a life with your donation, especially if it's a family member in needing of help. This is one way you can save their lives now. Now, of course, in the public, people are good Samaritans who are willing, because sometimes we do not. When we want to transplant, we try to reach 100% HLA match transplant, where the genetics of the donor and patient match, mainly to reduce the risk of the graft versus host disease, we will try to make it as match as possible. And we do have unrelated. We have a stem cell bank. Locally, it's not so established, but those in Singapore, Taiwan, US, China, they have a whole list and a patient who are willing to donate. The challenge is the arranging a timing to get the donor. By the time usually we get the donor, sometimes the disease has relapsed, and also to get another thing is cost to bring the stem cells to Malaysia. So that's another thing. Yeah. So that's the challenges lah. And the other yeah, basically there's the risk to the donor lah. But otherwise should be okay.
Minimal lah, quite minimal.
Yeah, minimal. Yeah. So you're saving a life actually.
Yeah, that's right.
Okay. So cell therapy, this is very exciting. Only is established in established not under clinical trial is for ALL, diffuse large B-cell lymphoma, and myeloma. Yeah. So what you do is this is your own. Usually it's still your own. You use your T cells. They harvest it. Yeah. They store it. They put the virus particle inside. So this virus particle is called the chimeric antigen receptor. So they infuse it back to the patient. Yeah. So this new armed T cells. So you give the your own T cells extra weapon to kill the cancer cells. It's almost like that bite antigen where you encourage the T cells to attack the cancer cells. Therefore, the risk is also similar. You get this cytokine release syndrome, which needs to be monitored and observed and treated. It happens after the T cells. So basically, you use your own immune system. You arm your immune system with a receptor to attack the cancer cells. So basically, almost like immunotherapy, but at a very, very, very high level. Yeah. So this is CAR-T. The issue is cost and accessibility. The original is in America, so the range is between if I change to ringgit, it's 1 million to 4 million ringgit. Then the other thing is we have a China option. Of course, China does everything much cheaper. It's about 10%. You can get a fraction of cost between 200,000 and 1 million ringgit. What
is the money? What is the cost for?
Cost for harvesting, storing, reinfusing this CAR, insert this gene, this viral gene.
You need to insert a gene.
Yeah, yes, you insert it. This is very high. You know the movie I Am Legend, when they say everything turned into zombies, is actually this. Is use this. So that high inflammatory state which turn people zombies is likely the cytokine release syndrome. This is my hypothesis, but it sounds very similar, and you can see the lady. But that in movies sometimes they have this knowledge of this. And so basically that's it. That makes it interesting. But it is expensive, but it is an option for treatment. So what you do is, so patient gets, it's not as simple. So that's why we don't have to think. That's why we're paying that 200,000 for it. So that's the reason. Yeah, it's not that simple. We make it simple by paying that 200,000 to 1 million ringgit for it. So yeah, so that's it. So basically insert this, you reinfuse the patient. Yeah, so
what if it doesn't work?
Yeah, there is a chance it doesn't work. Basically, you still have to use other salvage therapies all cancer. Yeah.
And you might not work. Oh my God.
Yes.
Okay, never mind.
Yeah, that's why I buy insurance. I should be an insurance agent so to tell people to get 3 million. I can be a good insurance agent seller. Okay, so finally we're approaching the end. So all this needs combined modalities. You can see in ALL, you have the chemo, then after they combine with allogenic transplant. Depends. Some just need maintenance treatment, but you have combined with targeted therapy, monoclonal. Same with AML lagi pening. Based on the risk stratification, you use a different chemo with combination. Is a AML lagi pening, but you can see many is ends towards allogenic transplant. So AML is still those one of those diseases that needs transplant. So is ALL as well. Yeah. CLL, not so also combination treatment. You can see here is divided based on the patient's fitness level, or the cytogenetic or the molecular abnormalities. So you use it. You try to keep as close to the guidelines, where you combine chemoimmunotherapy or immunotherapy or targeted therapy, either in alone or in combination. CML, you can see here, all is the oral therapy. This is but if it relapse, second line, third line, if you need a second line, you need to prepare the possibility. It still can fail, because when you say 80%, that 80%, 90%, that 20% remaining still may need transplant. So there is still a risk of requiring transplant. Yeah. So landmark successful treatment, as I said, the CML and APML. Others are still really challenged by it. So challenges in leukemia treatment: acute leukemias remain difficult to treat. There's also issue of intensive chemotherapy for acute leukemias, the toxicity, and long-term complications of bone marrow transplant, especially allogenic transplant. Duration of treatment, sometimes with the target therapy, lifelong, indefinite. And finally is the financial toxicity, the cost. So I hope the talk today is concise enough and managed to entice everyone's interest in the topic. And I think I exceeded my time, because it's still quite a large topic to cover. Okay, so I stop share.
I think it's quite interesting, a little bit difficult for my simple brain to take enough. You know, I only got
it is a dry it is a dry topic, but okay, I hope people can get an idea that what our hematologists are doing, and what we really do, and is not simply just picking out chemo, and give the benefit of doubt to the doctors who are treating, that not all chemos are bad. And you still, despite the advances, we still scratching the surface of this of leukemia treatment. Hopefully, in a decade, we'll be heading towards targeted therapy and immunotherapy surgery without chemotherapy. That's the aim,
And also how the therapy has changed over the course of the years. Quite amazing that some are just on oral therapy. Okay, so are there any questions? Because we will share, how you call that? We will share the link to the QR code at the end of the Q&A. I'm checking Facebook. So Facebook had a huge attendance. We had about 150, 60 people watching in.
Okay.
And of course, we were full here. But any questions at all? Okay. So let me.
I hope people are not discouraged.
Okay. When do we foresee that we will start our Beacon will start our bone marrow transplant program?
So we already start. We are ready to accept patients of the autologous, because allogenic, as you can see, is another beast to handle, and we need and our staff. I wish to take it step by step by doing autologous therapy, treatment, and later CAR-T treatment, where we are ready for that as well. So because the setup is similar for autologous bone marrow transplant and autologous CAR-T. Allogenic, I need to make sure the staff are ready first, because you need dedicated nurses, not mixed with other onco and anything, just to take care of the transplantation. So it's another thing to think about. But with autologous, we are ready. If anyone has any opinions or need to refer patient to Beacon for autologous transplant, do refer, and we'll try to support. We start small, 1 bed, but hopefully we get 4 or 5 beds in a few years after the Beacon 2 is completed.
Okay, somebody asked, is leukocytosis a kind of leukemia?
No, leukocytosis is basically an increased white cell. Yeah, so leukocytosis, to those who want to know, is basically increased white cells. You still need to rule out whether you have infection or inflammation. Yeah, so sometimes people take steroids or traditional medicine that contains steroids. It may increase. But it is good to have, when you see leukocytosis, to have your blood peripheral blood film to be reviewed by a qualified hematologist or hematopathologist to have a look, and whether it's sometimes a lot of patients have incidental finding of leukocytosis, because especially those with chronic leukemias, they turn out to be leukemia. But some of them with CLL, they do not even need treatment. They just need to be monitored every month or 3 months. So if it's persistent and it should be looked at, at least a basic peripheral blood film would and a normal checkup by the doctor to look for organomegaly or lymphadenopathy should be enough.
Okay, somebody asked from Facebook whether AML or ALL is more common in Down syndrome children.
Yes, you have in Down syndrome you may get it's more common with the AML. So it is more related to kids. Not to say that every Down syndrome kid will have it, but it's more closely associated.
So if let's say a group of normal children and a group of Down syndrome,
they have a
higher risk of AML.
Yes.
I see. I didn't know that.
Yeah.
Oh, that's okay. So we will end here. I will stop the live.
Okay, thank you.
Hold on, let me just share okay, let me just share this one. Okay.
Thank you for everyone's attendance, and thank you for having me here.
Yes, thank you very much.
Okay.
And